Vomiting is a common symptom in at least 70% of pregnant women, and this is known as morning sickness. Vomiting is even considered as a protective defense mechanism in pregnancy in order to reduce exposure to potentially teratogenic agents like bacteria and toxins, which may have undue effects on baby. That's why morning sickness is very common in the period where the fetus is most vulnerable to teratogens, that is, during the organogenesis period. However, if vomiting becomes so severe and intractable, resulting in dehydration and weight loss, it is termed as Hyperemesis Gravidarum. There are several factors contributing to Hyperemesis Gravidarum in pregnancy, one of the factors being raised serum beta HCG levels. Therefore, this condition is commonly seen in women with higher HCG levels like multiple pregnancies and hydatidiform mole. Also, the onset of the disease sets in the first trimester, where HCG levels are highest. Symptoms get better after 20th week of pregnancy due to a fall in beta HCG levels. The reason why HCG causes vomiting is that it stimulates estrogen and progesterone production, which causes relaxation of stomach. This causes stasis of food boluses in stomach, which further block and irritate the stomach, leading to nausea and vomiting. Estrogen also relaxes the lower esophageal sphincter, and this causes gastroesophageal reflux disease or GERD. Hyperemesis gravidarum may also be caused by a genetic factor, as pregnant women with family history of hyperemesis gravidarum in first-degree relatives seems to have a higher incidence. The studies have found that two genes, GDF15 and IGF-BP7, have been potentially linked to the development of hyperemesis gravidarum. There is also higher incidence in women with history of similar attack in previous pregnancies and history of Down syndrome. Severe vomiting leads to loss of fluid and electrolytes, leading to dehydration, electrolyte imbalances, nutritional deficiencies, and weight loss. Significant dehydration may result in hemoconcentration, thereby increasing blood viscosity and risk of thrombosis. Another consequence of severe dehydration is hypovolemic shock, a condition of inadequate organ perfusion and organ failure caused by intravascular fluid loss. Inadequate perfusion to kidneys may cause reduced glomerular filtration of urea and creatinine, resulting in acute renal failure. Inadequate perfusion to liver may cause liver ischemia and hepatocyte damage. Prolonged and repeated bouts of vomiting cause loss of sodium, potassium, calcium, magnesium, and hypochloric acid, leading to hyponatremic, hypokalemic, hypochloremic metabolic alkalosis. Severe vomiting can also make the person in extreme lack of energy. If the body cannot get enough glucose for energy, it will start burning fats. This process occurs in liver, and it is called beta oxidation, and the end product of this process are ketone bodies. Ketone starts to build up in blood and excreted in urine, leading to ketonemia, ketouria, and ketoacidosis. Therefore, severe hyperemesis gravidarum can cause metabolic acidosis as well. You may also see raised thyroxine levels, as beta HCG is structurally similar to thyroid-stimulating hormone or TSH. Even though thyroxine levels are high, patients are clinically euthyroid, so treatment with antithyroid medications are inappropriate. Severe vomiting causes sustained increase in intraluminal pressure of esophagus, causing esophageal tear, known as Mallory-Weiss syndrome. In rare cases, it might even rupture the esophagus, which is known as Boerhaave syndrome. Diagnosis can be made with the triad of nausea and vomiting in pregnancy with more than 5% weight loss, dehydration, and electrolyte imbalance without any other pathological cause of vomiting. Mild to moderate cases have no effect on the baby. Severe cases are likely to have both maternal and fetal compromise, like Wernicke-Korsakoff syndrome, secondary to vitamin B1 deficiency. Severe dehydration results in hypovolemic shock, leading to reduced placental blood flow and potential intrauterine growth restriction or miscarriage. Abnormal liver function may also be seen in this case due to malnutrition. The exact mechanism has not been identified. However, some have hypothesized that malnutrition activates a process known as autophagy, which literally means self-eating. This is a normal physiological process that involves removal of damaged cells and cellular structures from the body. In this process, there is a possible chance of removal of damaged hepatocytes. This is also known as starvation-induced hepatitis. The diagnosis of Hyperemesis Gravidarum is made by method of exclusion, after ruling out the other causes of vomiting in pregnancy like appendicitis, gastroenteritis, typhoid, H. pylori infection, UTI, and drugs causing gastrointestinal upset. So make sure to ask these symptoms in history taking. Physical exams should include assessment of hemodynamic status like pulse rate, blood pressure, urine output, and conscious level. Signs of dehydration and signs of malnutrition should also be checked. Abdominal examination as well as pelvic examination should be performed to determine the presence of tenderness to rule out the alternative diagnosis. Perform urinalysis to check for ketonuria. Full blood count and serum electrolyte levels must be evaluated. Elevation in hemoglobin or polycythemia may be seen due to hemoconcentration. Hematocrit or packed cell volume is also increased in hemoconcentration. Arterial blood gas analysis may reveal metabolic acidosis or alkalosis. It is also necessary to perform thyroid function test, liver and renal function tests as well. Radiological studies like abdominal ultrasound and pelvic ultrasound may be considered to rule out multiple gestations and hydatidiform mole. Treatment should be guided by Royal College of Obstetricians and Gynecologists Green Top Guideline. The treatment depends upon the severity of the disease. The severity of Hyperemesis Gravidarum can be classified by using PUQE score. Scores under 3 is considered as mild cases. Scores between 7 to 12 is moderate, and scores above 13 are severe cases. Treatment of mild cases should be given with complementary therapies like adding ginger to the diet, acupuncture, and acupressure therapies. Anti-emetics should be given in moderate cases. Antihistamines and phenothiazines are used as first-line anti-emetics. If the patient is unable to take the drug orally, parenteral or rectal route may be necessary. Metoclopramide is used as second-line therapy. If the patient has at least one of the followings, consider inpatient treatment. Patients unable to take oral antiemetics. Symptoms unresponsive despite oral antiemetics. Presence of comorbid diseases or complications. If the patient is hemodynamically unstable, resuscitate her by keeping her nil by mouth, give venous access, and start intravenous fluid therapy. Normal saline with additional potassium chloride is the most appropriate intravenous solution. Corticosteroids should be reserved for cases where above measures have failed. Antiemetic effects of corticosteroids is due to reduction of serotonin levels, which causes gastrointestinal symptoms like nausea, vomiting, and diarrhea. Serotonin levels are also lowered by nicotine. That's why maternal cigarette smoking is considered as a protective factor for Hyperemesis Gravidarum. However, it is not recommended to smoke during pregnancy. H2 receptor blockers or proton pump inhibitors may be used for gastroesophageal reflux disease. Thiamine and folic acid supplements should be given. Thromboprophylaxis with low molecular weight heparin should also be offered. Termination of pregnancy should be considered when all above therapeutic measures have failed or when there is development of fetal complications. That's all for now. See you guys in the next video. Study hard and take care.